So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together.
Welcome back to the third episode with John Abramowitz on OCD. We just covered in the last episode looking at what treatment for OCD looks like, what we're trying to achieve, some pitfalls that we're trying to avoid, and what effective treatment looks like. We briefly touched on using value work in doing treatment for OCD. And so basically what I wanted to do was to spend a minute talking about that. We'll get into medication versus therapy, and then what it looks like at the end of treatment. How would you describe using value-oriented behavior when it comes to doing exposure work? And why might that be important?
Yeah. So in addition to helping people to reduce their obsessions and compulsions, we want to help people with OCD be able to get back into their lives and have productive lives and do the things that are important to them that make them happy in their life. And so I think that it's important to clarify what a person's values are. Now, I learned this from Mike Tuhig, who is an ACT therapist, and we worked together on a study, I mentioned it before, on an ACT-based exposure therapy. And he kind of taught me the importance of clarifying a patient's values. So we're not just doing exposure therapy for the heck of it. We're doing it so that the person can get back into their life and enjoy the things that are important to them. How does that translate into practice? One activity that I do with not everyone, but with more and more people who come in towards the beginning of therapy, there's a values clarification exercise. It's called the values bullseye. And you help people, I won't get into all the details, but you basically help people to identify what are the important things and what do they want their life to be about, right? And we identify 5 to 10 different things in their life, maybe as far as their relationships with other people go, or as their work or school goes, or their leisure time, or their personal health. We identify them and we take a look at how much are those things affected by OCD, to what degree are each of those 5 to 10 different important areas of their life affected by OCD. And we're going to use that information as the reason to do exposure therapy. So some of these things, they're having trouble with school, let's just say, or performing at work, or they're having trouble with their relationship. Well, that's a good reason to do exposure therapy. Something as challenging and difficult as exposure therapy, there's some, incentive there. If you say, well, yeah, if I do this, not only will I feel better, but maybe my relationships will get better. Maybe I'll be able to function at work or at school better. Okay. And of course, then the person will be able to do those things, which is wonderful. So when we're doing exposure, we're going to tie that into those valued activities. And I think I mentioned this before, but let's go back to the example that we were talking about before of the person who they think that they hit someone with their car, right? So maybe they're driving home from work at 5 o'clock and they hit a pedestrian. They get an obsession. They hit a pedestrian. They, of course, didn't really hit one. And now they're home. Now it's later in the evening and they're sitting down to have some nice time. Maybe they're going to watch a movie with their spouse or their partner, right? And at their home. And this person is just having obsessions over and over again. Oh no, what if? I can't possibly watch this movie and spend quality time with my partner, with my family, if this obsession is going through my head. I've got to go check, or I've got to go in my room and try to figure this out, or I can't be present. The person's not able to be present in the moment and but just show up for the, family time, relationship time. Well, what I want is that person to learn that, yes, you can show up. You can watch a show. You can go to bed. You can go to school. You can do whatever. Be intimate with your partner, even if that thought is going through your mind. So we're going to tie exposures to the valued behaviors. So remember that script we were talking about where you're going to write out, maybe I hit this person, maybe I didn't, or now the police are going to show up at my door. I want them to do the exposure, not just in a room by themselves where they're just kind of waiting for their anxiety to go down, but I want them to do it when they're in that moment. They don't have to tell other people that they're thinking about it. They can go somewhere, read the script, or have a reminder. Maybe they, I don't know, put a C for car. They write it on their hand, and they're going to look at it while they're watching the movie, while they're with their loved ones. And they're going to teach themselves, I can show up for this even when I have the obsessional thought, even when I'm doing the exposure, even when I haven't done a ritual, right? So I touch the floor. Again, another example. I touch the floor. I'm all contaminated. Well, I can't eat when I'm contaminated. No way. I can't do it, right? And tonight I'm going out with some friends and we're going to have a great meal. Oh no, how am I going to be able to do this? I want that person to learn, yeah, you can go out with your friends, have a nice meal, even when you're contaminated. So let's touch the floor, and then you're going to go out with your friends. And it might be difficult, it might be challenging. But if you get in there and you stick with it and you focus on what you're doing, and by the way, that you're contaminated, right? We don't want to distract ourselves from that. You will learn that you might not feel great the whole time, but you will see that you can show up. You can do these things even when you're having anxiety, even when you're having obsessions, even when you're having uncertainty. And so that's how I define kind of values-based exposure. It's a very ACT-y, acceptance and commitment therapy kind of approach. And again, if you're a good exposure therapist, and even if you don't know ACT, maybe you're doing this. ACT doesn't have a monopoly on values, but they sure do make it more explicit in ACT than it ever was in regular exposure and response prevention. It was always there, but it was more implied. But ACT makes it more explicit. And I just think that's wonderful. And so to me, that's values-based exposure. We want to get the most bang from our buck from each exposure. So it's not just about let's wait around for that anxiety to go down, but let's go and let's lean into it. And people sometimes will say, and I hear patients and clinicians say this, so I just have to sit with my anxiety? And I tell them, no, you're not sitting with anything. You're acting with it. You're operating with it. You're getting on with life with the anxiety and proving that you can do that. So I think that's a big part of the grit, that you were talking about before, Jason.
Mm-hmm.
Yeah.
So another way that I like looking at it too is finding that, okay, let's say someone has the value that going to church is very important to them on Sunday for their quality of life, their spirituality. I want them to be able to go to church, but their contamination fears is preventing them from going to church. So if we could use the value-oriented behavior that they want to do in order, okay, this is our goal. Our goal is for you to be able to sit through a whole Sunday service with your family.
Yep.
So we are going to orient these behaviors with that goal, with that specific goal in mind. I think it could be a very powerful way to get people more motivated. And then you're also helping increase the behaviors that are important to them. Even if you're not doing that and you're just treating their contamination, you are unlocking them so they could go to church and do it. But, but this could be, I want to be able to go to the park with my son. But right now I'm so scared that he's going to get hurt that I can't go to the park. And it's going to make me feel like a great dad if I could do that.
Yeah. And the patient's going to say, but if I go to church, if I go to the park, I'm going to be anxious the whole time. And you know what you say as a therapist? Yeah, you might be, but you're going to do it. You're going to show up and you're going to learn that you can do it even when you're anxious. You're going to do it anxious. You're going to do it scared. And that gets back to what you said before. Anyone can go to the park if they're not scared, but it takes a lot of bravery to do it when you are afraid. Anyone can go to church if it's not scary for them. But, if you're going and you're contaminated, that's, now we're talking, now we're getting somewhere. And so I don't care if they're anxious or not. I don't say it that way, but I don't care if they're anxious or not. I want them they'll get more out of it if they are anxious. They'll see that, I was anxious and either my anxiety went away and I was fine, or my anxiety didn't go away and I got through it and I learned that I can get through it.
And I did the thing I wanted to do.
And more importantly, I did the thing I wanted to do. Yeah, I showed up for it.
Yeah, I got my son to the park, and he had a great time, and I haven't been able to do that for a year.
That's huge.
Or 6 months. So yeah, that's huge for people.
Yeah.
medication versus treatment without medication versus just medication alone. Where do you fall on that? Well, let's start there.
Yeah, I think that overall, the research suggests that, again, the averages, medication is not as effective as exposure and response prevention. There have been a number of studies head to head, and at best, they're equivalent. But for the most part, the relative efficacy of medications is lower than it is for exposure. That said, I know lots of people who come in to, for an evaluation and they are on medication and it has saved the day, and that's great. And I wouldn't change a thing. I would never counsel someone to come off medication if it was helping them. Personally, as a clinical psychologist, not surprisingly, based on our conversation, I think that people are better off when they learn that they don't have to be afraid or take a drug for anxiety or OCD. But you know what? Not everybody thinks the way I do, and I respect that. And I think that that's totally fine. If you want to take medicine and it's working for you, the main thing is that it works for you. So there are plenty of people that take medications without anything else, and they do great, and that's fine. Often what happens is they're taking a medication, and sometimes, there's a jump start and folks are doing really well. And then when we see them in our clinic, sometimes the medication has kind of it's stopped working, or it's never really got them all the way home. And so they want more, they want something more. And I do see a lot of evidence from clinical experience and also research that if you're on medications and you're not happy with where that's gotten you, you can do cognitive behavioral approaches, primarily, ERP, and that will help you to do even better. It doesn't work the other way around. If you're doing ERP and that hasn't been helpful, usually taking a medicine is not going to jumpstart the ERP. Again, you can, if you're a clinician out there watching this or listening to this, you could probably find an example that goes against what I'm saying, because anecdotes are out there. But by and large, that's generally not what happens. Should you use both? The common adage is two heads are better than one. I am not sure that applies to the OCD literature. The well-conducted studies suggest that exposure therapy is just as good as, you don't get an advantage for adding medicine to exposure. That exposure therapy is just as good as the combined treatment. There are a couple of really well done, carefully controlled studies. They're a little older now that suggest that. But again, a lot of this is trial and error. People are people. Everybody's a little bit different. Everybody responds to medications different. People respond to, cognitive behavioral interventions differently. So sometimes it just comes down to trial and error. But in the name of clinical science, psychological science, we do want to, keep track of the literature, and we do want to have our first guesses be based on the literature, and then go from there.
If you have a client that's working with you, do you, and now we're getting into like your own personal approach, will you recommend a psychiatric medication evaluation at some point if the exposures aren't doing what you're hoping that they will do?
Yeah. So if we've done exposure and I feel like we've done it really well, and either they're having trouble doing the exposure, or we've done it and it just hasn't gotten them, we've done it well and it just hasn't gotten them all the way home. And I'm kind of throwing up my hands. Well, we've been meeting for, a good trial of exposure therapy. This is what I can offer. Sure. Yeah. Let's try something else. Absolutely. Yeah.
And then there are some people.
And by the way, I'll just say I've recommended people for ACT before. I've recommended people for ICBT before who weren't able to, do exposure therapy. These are all treatments that have some support. And if the first line intervention doesn't work, you try them. Absolutely. Sorry, I didn't mean to cut you off.
No, that's fine. Yeah, because there might be a different pathway that this person needs activated in order to get the results that we're looking. Just because something works for most people doesn't mean that it's going to work for everybody.
Exactly.
And I think when you, like everybody, well, not everybody, most people have taken headache medication, and there's some people that take Advil, there's some people that take Aleve, there's some people that take Tylenol, and you know which one that you take.
Yeah.
Because you know that one works for you. But if you think about it, Aleve and Advil are both NSAIDs, like they're cousins.
Right. And as are the medications that work for OCD. A lot of them are like the Me Too drugs. The different drug companies all wanted to have an SSRI. And there's debate in the field about how much of their effects are placebos and versus, because serotonin doesn't really seem to have much to do with OCD and what the research suggests. So serotonin reuptake inhibitors are really curing OCD by changing serotonin reuptake. I don't know.
Yeah, it could be a cascade effect, but I mean, there's a lot of possibilities. There are some clients that you come across that are like exposure would work for them, but they might not be a great candidate. And I'm thinking like a teenager that has ADHD, they know they have OCD, they don't want to do the exposure. They don't, it's like trying to wrestle a crocodile. I have no clue why I said that, but it's like trying to wrestle a crocodile, and they just don't want to do it. In those cases, sometimes what's important is that they get better.
Yeah. Oh yeah. Yeah. Sometimes people don't want to do it. In the initial session, I usually talk about the pros and cons of medicines. If someone hasn't had treatment before, which is the rarity, right? Most people usually they've had drugs, right? They've had medications first. But sometimes people have never had treatment before. This is the first time they've been diagnosed. We talk about the pros and cons of both. I'm very open about that because I want the person to get help, even if they don't do my therapy, exposure and response prevention, my bread and butter. I want them to get help. So you tell me what sounds good to you and we'll make it happen. If you want a referral, I'm happy to give you a referral. Yeah.
Talking about getting better, what does treated OCD actually look like?
Great question. It can range. So for the most part, as we talked about, way back, in episode 1, everyone has unwanted thoughts and everyone has ritualistic behavior sometimes. So it is not an absence of those things, and nor is it an absence of anxiety or uncertainty or feelings of disgust or whatever. I think I would define treated OCD as where the person has a healthier relationship with their intrusive thoughts, with their anxiety, with their uncertainty, and where they have the confidence that when those things show up for them, they don't have to avoid or push them away or do rituals, but they can continue doing the important things, the valued activities in their life, despite those guys showing up, those unwanted guests, I guess, showing up. I'm going to put it in my back pocket and I'm going out with my friends, right? Or I'm going to watch that TV show even though I'm having that thought. And this thing, it might bug me, but it's not going to bully me into changing my routine. Mm-hmm. To me, that's a good outcome. You do have some people that they never think about pedophilia again. I would think that's the rarity. And I don't think people are being completely truthful if they report that. But you can see you usually will see a reduction in anxiety and in intrusive thoughts, because once you're not so worried about them, those things have a tendency of kind of calming down. But, and we all get anxious sometimes. We all have intrusive thoughts. So we want to be better at those things, not better at making them go away.
Yeah. And I think your point there is the more that you don't want to think something, the more you're going to think it. And so the actual frequency of the thinking of the thought goes down, the less you care about thinking about it, which is, sounds a bit paradoxical. So the goal is not to never have the thought.
Right.
The goal is to have a managed ping, getting pinged from the thought.
I like that. Yeah.
And then not behaving in the OCD compulsive manner or the avoidant manner when you do get pinged.
Yeah. I did an initial assessment with someone just a couple weeks ago who had unwanted thoughts. They were married and they had unwanted thoughts, sexual thoughts about, other people. Right. Again, we all have that. Don't tell my wife, but we all have those thoughts sometimes. It's just the way that it goes. Doesn't mean that I'm not in love with my wife. My wife is wonderful. But this person said, you got to help me make these thoughts go away. And so that I never have them. And I said, well, that would be nice, but that's just not, I'm sorry. That's just not, it doesn't work that way. And in fact, having that agenda, trying to make that happen is actually going to make them worse for you. And he was like, I think our session's over. I got to find someone else who can help me to do that. And I wished him luck. But there are people who have that idea that that's the goal. And it's not because we don't have the techniques to make it work. It's because it can't work.
Yeah. It's an impossible goal.
Yeah.
And sometimes when you have someone like that, I'll say like, all right, well, why don't you try the treatment with me for a while, see if you feel like you're getting better. And then if the exposure is working and their pings are getting less, the idea of being able to tolerate having these thoughts goes up. So the idea of living a life and having them becomes a more tolerable thinking. That doesn't always work.
No, this guy was I tried all that stuff. This guy wasn't hearing it. And it, just with this person in particular, it became clear that the more I tried to, double down, the more he was just kind of doubling down on his position. And finally, I kind of said something like, wow, I wonder if this is a good match. If it's going to be a good match. Because, I could see every session turning into an argument. Right? How come it hasn't gone away? Well, that's not the goal. Well, but it should be. And he was the one who suggested, maybe I'm not in the right place. What I wanted to say was, I don't think you'll ever find that person. And if someone tells you that they can do that, they don't know what they're talking about, but that's up to him to find out. Natural consequences.
Yeah. I think the story that John Grayson told me, who's a big OCD guy, was he had someone that was working with another therapist. They recommended he go see John, and he's in his OCD was around his family dying, his wife and kids. And John said to him, well, the goal here is for you to be okay with the idea that your family has the possibility of dying, because that's just the reality of it. Yeah. And the guy said, nope.
What?
Never came back. Like, absolutely not. That's not a good thing. And then he didn't come back. So you'll definitely find people who are not ready for the base of the treatment in order to do it, but they might not be ready yet.
Right. And just to clarify, we're not talking about being okay with your family dying. That would be tragic and awful and terrible, and you would get through it. And eventually, most people find a way, and this does happen, unfortunately, they find a way to survive. But what Grayson was talking about probably was okay with the idea that it could happen.
Yes.
And now that we're talking about, I don't know if you have a family, but I sure do. And that thought just went through my head. And of course, I'm okay with the idea of it because, I'm an OCD specialist, so I know that. Mm-hmm. But most people are okay with the idea. In fact, books and movies and stories have been written about those very things by people who are cashing in on these terrible ideas and all of that. Of course, most people are okay with the idea. It's not a fun idea, but you're right. We got to be okay with the possibility of, or else what, right? Mm-hmm. Like, you can't eliminate that.
Yeah, well, we have to live in the world of probable, not possible.
Exactly.
Yep, and I think that sums it up there. Yeah, is it possible that something bad could happen to your family? Yes, it's not probable. So then we have to live our life in the world of probable. But some people want there to be no possibility of the outcome of what they're looking for, and that's one mechanism that we're trying to work with. That's the uncertainty tolerance of being able to have that uncertainty that the thing that's possible, because anything is possible. The moon might be a dragon egg. That's a Doctor Who reference. But, like, I don't know. It could be. How do we not know? It's not a space dragon egg. Right. Anything is possible. In Manhattan, you could walk down the street and air conditioning unit could fall out the window, and that could be it. Yep. It happens. It doesn't happen all the time, but we walk around knowing that the probability is low, even though it's possible. So it's living in probable and not possible.
Yeah.
Okay. Any last thoughts about OCD treatment, what it looks like when someone has successfully treated OCD? It's not that it's completely gone. You know what? I will make one last thought. I often give back pain as an example, because a lot of us have lower back pain, and it's something where, like, the back pain is going to be there. It might be there all the time. Sometimes it might be pretty low that you don't realize it. It's going to get triggered. And then the things to do in order to get it back under control. And that's how I view what treated OCD we hope will look like, even though people don't necessarily always get all the way to there.
Yeah. Yeah. To see those obsessions as a nuisance, the uncertainty as a nuisance, right? Like pain would be instead of a bully. Right. Mm-hmm. I'm going to stay home and not do anything because my back hurts, versus, my back hurts, but it's a wedding that I have to go to today, and I'm gonna show up for that, and I might feel some discomfort, but I might feel more than some. I might feel a lot of discomfort, but I'm showing up. And that is the treatment for. I worked at Mayo Clinic for several years before I came to North Carolina, and that is exactly the treatment for pain as well. Yeah.
So any last thoughts about treatment? No, I think
It's
you covered
hard
it pretty well.
for folks who might be tuning in who are starting or veterans of doing this, because it's hard. I've been doing this for a long time. I know a lot about it. I've written books about it. Not all of my patients get better by a long shot. A lot of them do, but there are plenty who don't. And it's hard. Everyone has their own unique presentation, and, we do the best that we can. And, it's challenging. But it's fun. I think it's fun. And even if the person doesn't get as better as you want them to, most times people will say that they learned something from the therapy if you're doing it well. They've learned something, even if it's just that everyone has intrusive thoughts and that I can manage uncertainty. I don't have to be worried about this. They might have a hard time actually doing it, but they've learned something new. I guess which is something. But this is a challenging field. I think any psychotherapy is challenging, but OCD. It's challenging, but it's fun, and it's often rewarding.
Talking about the power of learning, when you have someone come in that doesn't know they have OCD and they think that they're the only one that's scared that they might be a pedophile, and you say, no, you're a dime a dozen that have walked through my door, and this is something that that could be so relieving.
Yeah.
Knowing
we often overlook how important psychoeducation is, because we're the therapists, we know it. Right. But if you have someone who's naive about this stuff and you teach them all about this, that's huge. That's a big gain right there. Yeah. Oh, you mean and I'll sometimes self-disclose my own thoughts that I have. Again, if someone's kind of really having trouble kind of grasping it, what would you think? The person saying, I'm a bad person because I think about, an extramarital affair, right? Have you done it? Well, no, right? And I would say, well, what would you say if I told you that sometimes I have thoughts about, I see an attractive woman at the beach or the mall or something, and I had some sort of thought about that. Am I cheating on my wife? Am I a bad person? And again, it just kind of shows that everybody has these thoughts. Even your therapist has those thoughts.
Yeah, and that's probably normalization is such a powerful. I think we learned that like day one of grad school, right?
Yeah.
But then we learn about like different techniques and this, that, and the other. And I think sometimes we overlook some of the fundamentals and the power of normalization, being empathetic, being a good human in the room, being caring, having regard for people, sending
big.
someone an email and saying, I know today was your due date. I hope all is well. I hope the baby is well, and the power of relationship and things like that. Jumping off OCD, but okay. Is there any resources that you could recommend? Any books that you think people should read if they want to learn more?
Well, so first of all, the International OCD Foundation is that's the flagship organization for, information, education about OCD. They have an awesome conference in the summer. It's in person, and then there's one in the fall that they've been having that's online. That's really a great place to go for resources, and you send patients there and students and all that. There are lots of books for clinicians and for patients as well. I've written some myself. But there are lots of good materials out there.
I guess looking at some of your stuff, do you have any books that you had written that you recommend, or anything that's coming out soon?
Yeah, I mean, and I'm shy about like just tooting my own horn, but yeah, I feel like I've written a couple of good ones. So there's a book called Getting Over OCD, like a 10-step workbook for taking back your life or something like that. But Getting Over OCD there's two editions. There's the first edition, second edition. Get the second edition because that's updated with all the latest stuff about ACT and exposure and all of that came out a few years ago, like right before COVID, I think. Then I've also written one for families. It's called The Family Guide to Getting Over OCD. And it's for families who have relatives who have OCD. And like, how do I support my loved one? I'm working on a book now. These are all published by Guilford Press. And Guilford, they come to me and they say, hey, your book's doing really well. You want to write, a family guide to OCD. So then they came to me a couple of years ago and they said, what about, like kind of like what we were talking about, that not everybody gets over OCD, whether they don't, they're for one reason or another, they don't do treatment. They, maybe they're afraid or they just don't have access to it, or they've tried it and it hasn't worked. Let's write a book for those people, because unfortunately there are probably more people who have not had treatment or not had successful treatment for OCD than people who have been successfully treated. And so this one is going to be about how do I live with OCD? And it's not about like, how do I perfect my compulsions, but it's more about like, how do I communicate with folks about OCD? I'm working on a chapter about it's called OCD in the bedroom, right? How do you manage that in your relationship? So, communication patterns, family relationships. How do you come out with OCD? How do you talk to others? How do you let people at work know? What are some of the things you need to know about work and the law around discrimination, around mental health things and stuff like that? That's all going to be in there. So that book is a little over halfway done. I'm supposed to have it done by the end of 2024. No, I think I'm supposed to have it done by the summer of 2024. And then, it usually takes 9 months or so. So hopefully a year from now, maybe that's coming out. That'll be really exciting. We'll have to talk about that.
Yeah, I think that's a great book, because as you said, not everybody gets better with our treatments. Even though they're great treatments, there's some people that need to live with residual symptoms. And what do you do then?
Exactly. And there's no place in this book where it says you should do exposure and response prevention. That's described as a treatment, but then it's like, okay, let's assume you're not doing that. How do we get by? How do we live with OCD? And I'm glad they asked me to do that, because again, I have found lots of folks, as we just talked about, who either they don't want to do the therapy, or it just, for whatever reason, it hasn't worked for them. Well, we don't just say, give up, we keep trying, but they could use some skills for how do I manage life? How do I live? I think it's going to be called Living Well with OCD, basically.
Yeah.
So that's exciting. I'm really enthusiastic about writing that.
No, that sounds like it's going to be a great resource. Well, John, thanks again for bringing your brilliance on the show and spending quite a bit of time with us.
My pleasure,
today.
Jason. Always fun to talk about this stuff. This is one of my favorite things to talk about.
Yep, and hopefully we'll have you on for some other topics like we were discussing earlier. So TBD, and stay tuned.
Sounds good.